My name is Ian McCall. This is a short talk on the pathology of solar keratoses. Now, actinic or solar keratoses, they're very commonly found in the aging Australian population, and it's simply due to the years of accumulated sun exposure. The damage is added to damage, and if your DNA repair mechanisms aren't good enough, then gradually sufficient DNA damage occurs for atypical cells to arise. Sometimes, as I say, clinically it's going to present as a localized scaly area, usually on a red base, and that scale recurs after it's been picked off. Sometimes, in fact, the scale will grow excessively, and you can get a thing called a Keratin Horn forming. But that's a bit unusual. Normally the keratin is only in small amounts, and it's not firmly held. You can easily pick it off. Now, the central feature of an actinic keratosis is disruption, crowding, and variation in the size and shape of cells occupying the lower two-thirds of the epidermal layer. Generally, in a solar keratosis, the atypia, the crowding, the changes in the shape of the nuclei, doesn't occupy the full thickness, only the lower two-thirds. There are a variety of subtypes of keratoses, but initially let's have a look at some images. We'll bring one over and have a little look at it. This is the typical hand you'll see in Australia of someone with a series of actinic keratoses. Some of these are quite thick and adherent. You can see the red base that they're attached to. If there's a lot of infiltration in the base, you have to consider that you might have an early SCC, that you've got full thickness atypia and that there's breakthrough through the basement membrane. You can get solar keratoses in other areas, such as these on the lips. Now, sometimes in the lips the keratin isn't so obvious. It's softer, it can easily come away, and you tend to have an erythematous base like this. You have to be careful that this isn't full thickness atypia and in fact SCC inside you. So these areas always have to be biopsied. Generally though, this is the sort of damage that you get with actinic cheilitis. And these are the exposed areas of the lip with scaly solar damage here. These areas they're not continuously wet. So what does a solar keratosis look like histologically? Let's have a look at one of the slides here. Actually, I think the one we want is this one. Let's take a look at this one here. See if it shows these various features that we were talking about. We just have to wait till this loads. My apologies this morning. My internet connection isn't as fast as it should be. Here we go. Here's a piece of skin. You can see this area of keratin here. If you go up and look at this a little bit more closely, you'll also see that there's an infiltrate of cells underneath this area of keratin. And when we go in closely and look at it, then you get the impression, even at this level, that there's a change in the arrangement of cells along the lower two-thirds of that epidermis. And if we go in just a little bit more, this should be more obvious. There we go, as it all appears to us. Look at the atypia of the cells here. Not the full thickness, but just in that lower two-thirds overlying the basal layer. These are lymphocytes, part of the inflammation that may be associated with redness. And this is the layered parakeratosis here, which is part of the adherent scale of a solar keratosis. The other feature that you see is this bluish change underlying the collagen in amongst these sebaceous glands, and this bluish change is solar elastosis. Sometimes in solar keratoses you will also get little buds coming off the base of the epidermis. Now you've got to look at these closely and make sure that they're not little budding basal cell skin cancers, but a degree of budding with some atypia in them can be a feature of actinic or solar keratoses as well. Let's slip back and look at the slides again. So these are some of the subtypes of actinic keratoses. The typical one we've just spoken about and shown. You can get an acantholytic solar keratosis. Remember, acantholysis means separation between the cells in the epidermis. So that means that in that lower two-thirds of the epidermis, you're going to get some splits in between the cells, some clefting. You can also get a hypertrophic solar actinic keratosis. And this is where instead of getting just a little bit of scale, you can get quite a thick build-up of scale. So you get a thick stratum corneum, and that's called a hypertrophic actinic keratosis. A lichenoid actinic keratosis, you remember in that last one we just showed you, you had this lymphocytic infiltrate tight up against the basement membrane. This is sometimes called a lichenoid infiltrate. And if you've got a lesion that suddenly becomes inflamed, much more redder, then it generally means that the body's immune system is reacting to it. And there's usually a tight lymphocytic infiltrate at the dermoepidermal junction. We call that a lichenoid actinic keratosis. A boinoid actinic keratosis is one which looks like Bowen's disease. Now, Bowen's disease is full thickness atypia, often with mitoses in the cells in the epidermis. And in a boinoid actinic keratosis, there is virtually full thickness atypia there, right up to the stratum granulosum. But there isn't any significant extension down the hair follicles, which there is in Bowen's disease. And the number of mitoses is limited in comparison to Bowen's disease as well. And lastly, you can get a pigmented actinic keratosis where you've just got excess melanin in the abnormal keratinocytes giving you a pigmented lesion. Now, we should be able to look at a couple of examples of that. Let's look at a pigmented solar keratosis. Bring that one over. This is on a man's face, and this is the lesion here. You may look at that and think it might be a lentigo maligna, but if you try scratching that and just rubbing your hand over it, you'll find that it's rough, and that's because there's a little bit of excess keratin on the surface of this. Usually a lentigo maligna, you don't have that. And if we look at the dermatoscopy picture, you'll see these partial gray circles here made up of dots around the follicular opening. Again, it can be difficult to, on this dermatoscopic picture, say that this isn't a lentigo maligna. But generally, the circles are made up of dots themselves, as against complete circles of pigment, which is more common in lentigo maligna. So those are the two features of an actinic keratosis. If we perhaps just look back again at that slide I showed you earlier on with the atypia in the lower two-thirds, the thick parakeratosis here, the lichenoid infiltrate, usually a little bit tighter against, a true lichenoid is usually tight right up against the dermoepidermal junction there, and the lymphocytes sometimes attack the cells at the dermoepidermal junction as well. We talked about an acantholytic solar keratosis. Have a look at this one. This is the ultimate in acantholysis. This is where an actual blister has occurred. And if you look at this specimen here, we make that a little bit bigger, make it a little bit larger. This is the damage here along the basal layer, and then suddenly the damage becomes such that acantholysis or separations occurring, but it's occurring to such an extent that it's causing separation of the whole epidermis here. And this change, which on close-up view, you can see the atypia of the cells in the lower two-thirds here, and normal-looking cells in the upper third. This was reported as a bullous actinic keratosis, where ultimately acantholysis has caused separation of the dermis down here from the epidermis because of the solar damage. You're more likely to see that in the elderly with very thin skin here in Australia. So, to return, This is some of the layers, some of the annotated image that we showed that earlier on. We'll just look at it again. The atypical cells in the basal layer, minimal extension down a hair follicle here, which you might see in Bowen's disease if that was full thickness atypia. This layered parakeratosis and the lymphocytic inflammatory infiltrate and the underlying solar elastosis. We were talking earlier about a lichenoid keratosis. Sometimes a lesion will just be sitting there and then suddenly it becomes quite inflamed. And this can occur quickly. Sudden onset of redness and irritation involving a pre-existing actinic keratosis. And when you look histologically, you've got this marked lichenoid infiltrate hard up against the basal layer here. It's part of the immune attack, and the lymphocytes are actually destroying part of the cells in the basal layer here. So that's the picture you'll see in a lichenoid keratosis. With the damage to the melanocytes here, the melanin will drop down into the dermis, and dermatoscopically it'll be taken up by melanophages, and it can look as a series of gray dots when one of these burns itself out. You'll get these gray dots of melanin in the dermis. So let's get back to the correct area. We've gone through all of those. We've looked at the pigmented solar keratosis. What we haven't shown you is the phenomenon of budding that can occur in some solar keratoses. And we haven't really talked enough about the Bowenoid keratosis. I need to get a good example of that and put it up here. But remember, with a Bowenoid keratosis, you've got full thickness atypia here, but it doesn't extend down the side of a hair follicle. So those are the main things that I wanted to show you with actinic keratoses. They are exceedingly common. We could just look at a couple of images again to end this off, because we had a few others that I did want to show you. This was a lady who had solar damage here that suddenly became red and inflamed, and when it was biopsied and looked at again, there was a marked lymphocytic infiltrate. This was part of a lichenoid reaction that was occurring. This is just an arm with even more solar damage than we showed you with the dorsum of the hand. And you can see areas where the skin's been frozen, where there's hypopigmentation. And another clinical picture of someone with very significant solar damage. There's very likely to be not just solar keratoses here, but areas of SCC in situ as well, especially when the skin's broken and eroded like this. So you'll find that some people regard solar keratoses as SCC in situ, as malignancy itself. It is a lesion that's ultimately going to develop into a squamous cell skin cancer. But they can go if the body's immune system reacts against them. So it's not inevitable that they're going to develop into a full-blown squamous cell skin cancer. But in a man like this, you've got a field change all over. You've also got a lesion in here that you need to look carefully at, looking to see if that's a BCC that's eroding. Scalps are a big problem. Balding men never wear their hats early enough, and again you can see the extensive area of solar damage here. These areas may be full SCC in situ rather than just partial atypia of the epidermis, so you need to look at them very carefully and biopsy them accordingly, and then suggest your treatment. So I hope you've enjoyed this little look through solar keratoses. If I get more good examples of an acantholytic one and good hypertrophic ones, then I'll put it up to you. I did, in fact, there was one I did want to show you here, an actinic keratosis with a cutaneous horn. We'll end with this. Let's just have a look at this one. Now we need to move this up a little bit, because that's all the keratin that we're seeing here, this layered pink structure, and there's the area that it's coming from. There's the solar keratosis, the hypertrophic solar keratosis, giving rise to this large column of keratin. This was a closer view of it. Again, you can see the atypia of the cells in the lower third of the epidermis here, and the parakeratosis, the nuclei within the layered areas of keratin above that. If we just go back one slide, look at the layers that we're seeing here. And this just shows you the degree of atypia, variation in the size and shape of the cells in that lower two-thirds of the epidermis. And it was reported as an actinic keratosis with a cutaneous horn. Remember, this is an important point the author here has made, that the cutaneous horn may be seen with benign or malignant epithelial proliferation, so you've always got to examine the base carefully with that keratin horn to see if there's in fact a full-blown SCC in the base of it. So this assessment of the base is fundamentally important. Well, I think that's gone through actinic keratoses. Thank you very much, and we'll see you for our next topic.